Okay, so my name is Joe Morita, and I am a senior acquisitions editor at Springer Publishing. I would like to welcome everyone to today's seminar, COVID and Beyond, What Every Nurse Needs to Know About Healthcare Finance, Economics, and Policy. This webinar is sponsored by Springer Publishing, and our presenter today is Dr. Betty Rambur, who is Routhier Endowed Chair for Practice and Routhier Endowed Chair for Practice and Professor at University of Rhode Island. Dr. Rambur served as the founding dean at the University of Vermont College of Nursing and Health Sciences and as director of the Holly and Robert Miller Caring for Nurses Initiative. She is author of numerous peer-reviewed journal and book publications on the topic of health policy, healthcare reform, and healthcare economics. Dr. Rambur received her BSN from the University of Mary in Bismarck, South Dakota, and her MSN and PhD from Rush University in Chicago. She is author of Healthcare Finance, Economics, and Policy for Nurses, a Foundational Guide, published by Springer Publishing, and the second edition will publish in April. Though the text is not the centerpiece of the talk, we will provide some information at the end of the presentation on the latest edition. We will compile questions and address them at the end of the seminar, but please ask your questions in the Q&A tab throughout the presentation. The chat tab should be used for any comments you want to address to others. If we do not get to answer all of the questions live, we will provide answers after the call. The webinar will be recorded and available to everyone in 5 to 7 days from now on springerpub.com. Everyone in attendance will receive an email with a link to access the recording when it's available. And with that, I'll turn it over to Dr. Rambur.
Thank you so much. I'm so delighted to be here with all of you today, and I thank you for spending some time with me. I'm eager to share some thoughts with you and also hear your thoughts. So as we get started as a community of learners, I'm really interested in knowing a little bit more about you. Are you a clinician, an educator, a scientist or researcher, administrator, a student, or other? If you'll just take a minute and answer this poll, we'll have a sense of who our community is today. Okay, let's see here. We have mostly educators, 80%, but 7% administrators and 7% students and 7% others. So welcome to all of you. Thank you for being here today. Oops. Sorry. So COVID-19 illuminated foundational cracks in the healthcare system, as you're well aware. Now, these were there before, but it's shown a bright light. We have exorbitant costs, with our care costing twice as much as the next closest wealthy nation. And yet we have very unequal access. We have a paradox of overtreatment and undertreatment, overuse, underuse, and misuse. And we certainly have tremendous challenges with disparities. We have underinvested in public health, and we've certainly seen the ramifications of that. But the pandemic also revealed the challenges with our dependence on elective procedures. In the month of April of 2020 alone, more than 1.4 million healthcare workers were either laid off or furloughed. And as one PA said, physicians, nurses, and nurse practitioners, others are essential workers until we're not. Now, why did those layoffs happen? Because the resources that run so much of our healthcare system are from elective procedures, and those dried up. Also, the pandemic revealed challenges with the employer-based system in that estimates vary, but roughly 14 million lost their employer-based insurance during the economic downturn related to COVID. Now, the massive COVID relief bill that was just passed is temporarily addressing that, but you can see some real challenges. So let's talk a little bit about this expensive healthcare system. We spend nearly $4 trillion a year on healthcare, roughly double the next closest competitor, if you will. And have you ever noticed that even before COVID, if you or your family was making more money, it didn't really feel like you were? Well, it's been very clear for over a decade that our exorbitant healthcare costs result in stagnant real wage growth. It contributes to our national debt. And if anybody's more things to be anxious about during COVID, take a look at the national debt. Even before COVID, we were having national debt that was spiraling out of control. And the people who are the economists really looking at this say we cannot get this under control until we get healthcare costs under control. Healthcare consumes nearly 20% of the gross domestic product, 18.3, which means nearly 1 in every $5 is spent in healthcare. Now, understand that erodes our potential to invest in other segments of the economy. For example, many of you know and see the dwindling support to higher education. Well, states in their budget are looking at Medicare costs for health insurance for their own employees, and supporting higher education. And students increasingly have serious debt loads. Erodes the opportunities for job creation, even when these factors, how well educated we are, what we do for a living, where we live, have far more impact on health than healthcare does. Now, different sources have slightly different figures on this, but it's all within the same ballpark. And I particularly like this one because it underscores our problem with having too much healthcare and not enough health. You see on the column on the right-hand side that medical services consume roughly 88% of that nearly $4 trillion. And yet for all that money, that 88%, access to care is responsible for only 10% of our health outcomes. So we're spending almost $4 trillion for 10% impact. Certainly healthy behaviors, you're all familiar with the impact of social determinants of health, et cetera. But the environment and genetics each at 20%. Now, even genetics is influenced by the environment and our behaviors because we do know that those things can switch genes on and off. So we are really putting a lot of money, 88% of nearly $4 trillion, for very little bang for the buck, so to speak. Now, very briefly, when we look at how we're doing compared to other nations, we're not doing very well. This is from the Commonwealth Foundation, and they rank wealthy nations in terms of their overall health outcomes, and you can see the different measures that they have. And every year when this is done, the United States is right at the bottom, the lowest performing. And Canada is often right in this mix as well, which surprises many people. Although Canada has a publicly funded single payer, reimbursement is fee for service, and that is associated with a lot of the challenges we'll be talking about. Here in this slide, you see performance relative to cost, and again, the United States is very much an outlier. So we're spending a lot of money and not doing particularly well on our outcomes. We, in fact, have a crisis of waste, a crisis of affordability, and a crisis of harm. It's well documented that 1/3 to 1/2 of our care is waste, unnecessary or low-value care. And even more shocking is the data that finds that medical error, healthcare itself, is the 3rd leading cause of death in the United States. Putting the immediate issue with COVID aside, 3rd leading cause of death in the United States. Now, medical error is always tragic, but even more so when it comes from something that was not needed or was low value in the first place. So how did we get in this situation? The waste crisis and the cost crisis is fueled by fee-for-service reimbursement. And it's pretty well accepted on both sides of the aisle that fee-for-service is a real problem. In fee-for-service, each piece of treatment management care is unbundled and charged and reimbursed separately. This creates fragmentation. We have payment silos, so we have treatment silos. It creates exorbitant costs because there really isn't an incentive to stop and think, is this really helpful? Is it really helpful to do X, Y, or Z? And we also have very short accountability horizons and very narrow accountability horizons. Now, what do I mean by that? If I'm well insured and I come to see you and I have this complaint and that complaint, you can just keep ordering tests and providing services, and and bill and be reimbursed. And there's really no incentive to stop and think, what's really going on with Betty? And so we'll talk about some payment models that are really pushing us in that direction to think, what do we do that matters? So what do we need to create sustainable change? We need nurses who are fluent in what I call the 5 pillars. So let's just talk a little bit about what we're talking about here. First of all, the financing of healthcare. How do we get the money that eventually is used for healthcare services? And I became very interested in this in 1993. I was one of 7 nurses invited to the White House to meet then President Bill Clinton to talk about healthcare reform. And as the granddaughter of an illiterate immigrant and the daughter of a woman who was able to go through elementary school before she had to go to the city to be a maid, I thought, this is the American dream. This is what education and opportunity can be. Here I am going to the White House to talk with the president about healthcare reform. And as I was standing in line for the security line, a man who was there for something else asked what I was waiting for, and I told him, and he said, "Oh, do you have typical nurse syndrome?" And I said, "What is that?" And he said, "All kinds of ideas of what should be done and absolutely no idea about how to pay for them." And I was a bit chagrined because exactly, I had all kinds of ideas of what should be done and no idea really even in how money was generated for the healthcare system. So I set out to really study this deeply and make sure that no one would ever say that to not only me, but any of my students or colleagues ever again. The next is economics, and all markets are imperfect, but healthcare markets are very unusual. And we've known this since the award-winning, or the work of Nobel Prize winning economist Kenneth Arrow, who launched the whole field of health economics. But this is a really important language for nurses to understand. We see all kinds of things about mergers and acquisitions, and nurses have a lot of skin in the game when that happens. Many things that you really can't understand without understanding economics, healthcare economics in particular. And a couple of years ago, I was working with some of my graduate students, and I was talking about cost shifting. I always read all my materials by my students so I can make sure I understand what's clear and not clear. And one of the best students raised her hand and said, "Dr. Rambur, that can't be right. It can't possibly be that way. I think you must be wrong." So I said, "Well, let's see." And we studied for the rest of the semester. And at the end, she said to me, "I feel cheated that I did not learn this before. How could I be 32 years old, a nurse practitioner, or a nurse becoming a nurse practitioner, and not have known this?" So I think these are absolutely foundational pillars. The next one is innovation, and I'll talk more about some skills for innovation in a bit. But think about this model that we have where we really socialize our students to the most part to find the right answer, because there really are better answers for drug dosages and things like that, and learn how to take orders and transcribe them. And then we say, okay, let's go be innovative. Let's think about new ways of doing things. Let's redesign care. And I think there is really an imagination and innovation imperative that only nurses can fill. And again, they need the tools and techniques, understanding the language, including the language of money. Next, leadership. And I like this slide, or this image, because we see there that the leader is standing alone, and it can be hard to stand alone. Some of you perhaps remember research that was done many years ago that found or suggested that people are motivated either by achievement or affiliation or accomplishment. And I think a lot of us in nursing really have a lot of affiliation needs, and it can be very hard to stand alone. And sometimes you're actually against the crowd and really taking on noise. So really developing those leadership skills, change management skills, but having them grounded in how you make things work with the finances as well as innovation. And finally, I just wanted to comment that over the years, I've become much more clear on the lack of clarity that many Americans have on the branches of government. there was a study done in Pennsylvania, a nationwide study that found 1/3 of Americans could not name all 3 branches of government, and 1/3 could not name any branches of government. And in exploring this a bit, I uncovered that as STEM education became so important, many schools replaced the civics requirement that had been a pillar, in the 50s and 60s with more STEM education. And I find that the students are really interested in understanding not only, how a bill becomes a law, how Congress works, or how their state legislature works, but administrative rules and executive orders and direct democracy, such as ballot initiatives and referendums. How the Supreme Court works. Why do they take some things up and not others? So in this particular edition, I've really expanded that because we hear things all the time in the news. I mean, the latest is the filibuster. And so how can we have an informed decision about these things when we really haven't been prepared to understand them deeply? So we teach our students all sorts of new languages. When they first start in the nursing program, they see this piece of squiggles and not know what it is. And it doesn't take them very long to know that it's a normal EKG. So we teach them all kinds of languages, but why not the language of power, which is the language of money? And we kind of, I think, as nurses have a little bit uncomfortable feeling with that, but money is morally neutral. It's not good or evil. It's all what's done with it. And taking their clinical background and knowledge and the trust the nation has in nurses and coupling it with the 5 pillars, nurses can really fly with 2 wings and really create change. Now, we always encourage our students to advocate for their patients, but this really takes an analysis and an understanding of the details. So for example, does advocating for our patients mean we support the 1 to 3 insurance band ratings that's in the ACA and supported by AARP? Or do we support the 1 to 5 insurance band ratings that would provide less expensive insurance to younger individuals, but more expensive insurance for those closer to Medicare age? So this is a complicated issue with thoughts on both sides, but to advocate, we have to first understand. Does advocating mean we support first dollar coverage, meaning no cost sharing, deductibles, or coinsurance, first dollar coverage to enhance access to healthcare? Or do we oppose it because of the well-documented phenomenon of moral hazard? Moral hazard is an economics term, which means you use more healthcare when you don't have any financial skin in the game. So where do we land on that? Many wealthy nations with very high-performing healthcare systems have some to a lot of cost sharing, and then some have very little to none. So what is the right answer for us? What would we advocate for when we're advocating for our patients? As a quick aside, Medicare itself has cost sharing a form of 20%, as you probably know. So does advocating for our patient mean support for the ACA subsidies that are benchmarked to the silver plan, as in the ACA, or to the gold plans, as opposed by President Biden when he was a candidate? So understanding things like metal levels are very understandable to the students when they're exposed to it. And at first, it's a little bit of a foreign language, but it doesn't take long, and they're in quite heated debates about it. So in other words, the details matter. Reasonable people can look at the same information and come to different conclusions. And so this opportunity to really moderate generous listening and learning through debate is, I think, really exciting and well received by students. So one of the things I've found that's very helpful is needing organizing framework that's within a cohesive story. So lacing, little vignettes with more scientific information. And most students have very little understanding, for example, about how the revenue that pays their salaries is generated. They might know it comes from insurance. They may know it comes from government through taxes, less clear on that. But helping them understand how insurance works, they can begin to see that the driver of healthcare insurance cost is the cost of healthcare. And that is driven by unnecessary care and wasteful care. Remember, 1/3 being waste and unnecessary care, maybe a half. And so those things contribute to a lot of use of healthcare in the United States, a lot of use of low value healthcare in the United States, and our prices are much higher. So when they start to understand that the cost of insurance is a reflection of the use of healthcare services by those people in the insurance pool, they can start to really think about thoughtful strategies about how they want to engage in creating a more affordable healthcare system. Now, I'm briefly going to talk a little bit about a spin through history, because I find that it's almost impossible to understand where we are today without knowing a little bit about the past. Healthcare in the United States is a history of flukes that had unintended consequences, and then policy fixes to correct those unintended consequences with still more unintended consequences. And I just would like to briefly share a little bit about what healthcare looked like at the beginning of the 1900s. Very different than today, obviously, but for more reasons than just technology. Hospitals were not someplace that people wanted to go. People who were hospitalized were people who had no place else to go or who were not wanted, primarily those with infectious disease, the homeless, and those that were considered, insane, to use the term that was used at the time. Now, this created a big problem for one group, hospitals. And what do you do if you build it and nobody comes? So in 1929, the Baylor Hospital had a pretty brilliant and radical idea. They thought, what if we offer the Dallas school teachers a list of services that they could have at our hospital for 50 cents a month? That is how employer-based insurance started in the United States, as a mechanism to assure a hospital was paid. This grew to become Blue Cross. And initially, medical groups were very skeptical of this. They didn't like this idea so much. But as the Great Depression grew and people did not have money to pay for anything, much less their doctor, Blue Shield of California was started, and then it spread across the nation. So from the beginning of our healthcare system, it was hospital and physician centric. But unlike the systems in Europe that were consumer driven, ours was driven by these organizations to ensure that they were paid. There was no attention to antecedents, care coordination, or cost. Now, one other piece of history that I'll just briefly touch on is the Flexner Report of 1910. That might seem like a long time ago, but we have that echo today in the shape of our curricula. And Flexner was hired by the Hospital Association to look at medical schools and try to get some uniformity. And his recommendations ended up creating criteria that ended in the closure of the schools that we now consider complementary and alternative, because they were alternative to this Flexner model, but also the programs that educated people of color and women. And in fact, it's been documented that the Flexner Report was responsible for the near elimination of women from the physician workforce from 1920 to 1970. So there's been a long echo, and I can't go into it in full detail here, but I think it's very helpful for understanding how we got into this place of such a hospital and physician-centric system in which nurses are considered labor costs and physicians revenue generator. It's how we pay for things. Finally, we're hearing a lot about public options and single payers, et cetera now. And I just wanted to underscore that this dialogue has been going on for over 50 years. It's still going strong. FDR proposed a form of national health insurance. You can think of that as like a Medicare for people regardless of age. National health insurance to be part of the original Social Security Act. And there was strong opposition from organized medicine, who called it socialized medicine, and I'll explain why it's not socialized medicine. So he pulled it out because he was afraid the entire Social Security Act would go down. We had an employer-based insurance company, and of course that leaves out those who are no longer working because they're either retired or disabled. And that really spawned the amendments to the Social Security Act in 1965 and started Medicare and Medicaid, there was again a thought of a national health insurance option that those 65 and above would just be the first group and the rest would roll in. And for a number of reasons, that did not happen. Republican Richard Nixon had a public option in his healthcare plan. And his plan for healthcare reform is actually more dramatic, more radical than the Patient Protection and Affordable Care Act that's often called Obamacare. And it's often joked that, it's water that brought down national health insurance in terms of Watergate in Nixon. And of course, we are again talking about Medicare for all, Medicare for more, Medicare for all who want it, the public option, Medicare X, which has been reintroduced. And we don't have time to talk about the similarities and differences here, but I just want to underscore what's the difference between socialized medicine and national health insurance. You can think of Medicare as a form of national health insurance for those who are 65 and above, and people of any age with end-stage renal disease or ALS. That is national health insurance. Socialized medicine is when the funds are generated through taxes, but the care is delivered by physicians, nurses, other healthcare providers who are employees of the government in facilities that are government owned. So in national health insurance, like Medicare can represent, funds are generated through taxes, but nurses, physicians, and others are employed in hospitals that are not for profit or for-profit organizations. They are not government owned. So when you think about that, you see we have forms of actual socialized medicine in the United States by this definition. The VA, places like Walter Reed, Indian Health Services. And when you look at Gallup's recent report, they found that those with with governmental insurance are far more satisfied than those with commercial insurance. Top on the list were those with VA or military. Second on the list was Medicare, third Medicaid, fourth those with commercial insurance, presumably because of price. And then lastly, the uninsured, who probably have a lot of reason to be unhappy with the situation. Know that before COVID, the single greatest healthcare concern that Americans had was the cost of healthcare. And I'm certain that that will be exactly the case on the other side of our pandemic. Now, one of my sort of points of pride is I have worked very hard to read and synthesize the 900-page law that is the Patient Protection and Affordable Care Act, also called Obamacare, and the 10,000 pages of administrative rules that go with it. And my inspiration for this was Einstein, who supposedly said, if you can't explain it simply enough, you don't understand it well enough. But this was about a 3-year challenge to really, how do I make this simple without being simplistic? And I am pleased, I have to give a shout out to Elizabeth Roberts, who is a former lieutenant governor here in the state of Rhode Island and responsible for implementation when the ACA came out. And so we went through this piece by piece to make sure it was simple without being simplistic or incorrect. So in just broad strokes, it's a hybrid model that builds on the existing multi-player model in the United States, retaining Medicare, Medicaid, and commercial insurance. There are elements of it that are policies to increase access to health insurance. Now, understandably, access to health insurance does not guarantee access to health care, but it's an important first step. And many of these are in the news a lot. You no longer can be denied a condition for having a pre-existing condition. It removed gender as a rating factor. It removed lifetime caps. It used to be that once you get to a certain limit, your insurance company no longer had to reimburse for care that you received. And families with a lot of chronic conditions hit those caps pretty quickly. Funds for Medicaid expansion, the exchanges, children can stay on their parents' health insurance till age 26, even if they're married or no longer dependent, go on and on and on. And of course, we now have the ACA at the Supreme Court. And if in fact severability means that the entire law was struck down, unless your state has these provisions in place, there is no guarantee that our insurance companies would not deny health insurance to people with pre-existing condition. I think my students find gender as a rating factor one of the most perplexing and surprising things, because before the ACA, unless your state had this in place, health insurance for young men could be much less expensive than for young women, because young women have the risk of pregnancy. And of course, pregnancy is expensive for insurance companies. So even though in general, men have a little something to do with this, gender as a rating factor had been in place in many states. There's also provisions for transparency, and I'll just name a few of these here. One is the Sunshine Act, which requires institutions and physicians to publicly report revenue that they get from manufacturers. And it doesn't mean that they can't accept it. It just has to be publicly reported. And there were conversations about including nurses and nurse practitioners in a revision to this. But with COVID, that's kind of, lost attention. But it was really interesting to hear this being played out. I remember one physician arguing that if the nation thought that someone like him would change his treatment decisions because of getting a mere $90,000 a year from a certain company, they were sadly mistaken. And I think most of us hearing that thought, I think that's kind of a lot of money. So the Sunshine Act, that's what that's about. And at least in our state, the Providence Journal reports those. But if they're not reported, you can find them, but it takes a little looking. Shared decision-making is sometimes called the sleeper provision of the ACA, and it simply means that patients and their families will be fully apprised of the options and be able to make the decisions that are best aligned with their values. Now, students will always say, well, that's just good care, but we know from our own experience that we still have, a lot of paternalistic things that happen. And one of the ones that often comes up from my students is people's end-of-life directives being modified and then being retained in the ICU when that wasn't what they wished, and et cetera. So shared decision-making inclusive of costs and potential outcomes is really, really important, and we have a long way to go. And then finally, because increasing access to health insurance doesn't necessarily decrease costs, there is also the establishment of the Centers for Medicare and Medicaid Innovation that tests many alternative payment models. And these have real opportunities for nurses, and I'll talk about that in a bit. So understanding that there's a lot of innovation happening as a result of the ACA. Now, I wanted to just talk a little bit about this move away from fee-for-service and the important opportunity we have if nurses begin to understand financial risk and take these opportunities. So think about in the current model in a hospital, nurses are the largest labor cost, while physicians are revenue generators. Nurses are a labor cost, even though if a person is admitted to a hospital, it's because they need nursing care, right? Otherwise, they'd be outpatients. So what these models begin to do is recognize that everything is cost, and we really have to start thinking about value. So let me give you an illustration, then I'll go through. In a traditional fee-for-service model, if you're thinking about children with asthma, one of the first strategies is to hire another pulmonologist, right? Because you'll have more kids with asthma. If you're in a system that has a global budget or a fixed revenue model, the first thing is not to hire an expensive pulmonologist who may or may not be able to change outcomes, but to think about, wow, is there something we can do for mold abatement? Maybe we should have a nurse or a social worker go into the home and think about mold abatement. Maybe we need an air conditioner to get rid of particulate matter that's sparking it. Is this child having a cat or a dog in the bedroom? You're starting to think about really the kind of outreach and effectiveness that nurses are so famous for. And certainly there will still be need for some specialists, but it starts to begin to turn to a much more human-centric, holistic form of care that nurses are that's us. So there's lots of different models out there, but just to briefly kind of put them in some bundles, there are models that are sort of like fee-for-service with little trading wheels towards value. And in these, the reimbursement is on a fee-for-service chassis, but if quality metrics are met, there's an extra reimbursement. So one that you're probably very familiar with, all of you, are patient-centered medical homes. Now, in these settings, people don't lose money if they don't reach those metrics. They don't have financial risk for their decision-making. They can just have extra. Another example is upside only, accountable care organizations. You can think of that as bonus only. Accountable care organizations are groups of providers that have agreed to be accountable for the outcomes of care, or in the case of two-sided ACOs, the outcomes and cost of care. And this is where nurse as value creator is so essential. So let's imagine a two-sided ACO. We're a group of providers and we're responsible for the outcomes and cost of care. And if we deliver that care for less than projected while reaching the quality metrics, we receive that extra revenue. In some cases, it's shared with the payer. But if our care is more expensive than projected, we lose that money. So there really starts to come an incentive to think about what's effective. Now, why is this so important? Going back to our issues of waste, right now in the United States, 1/3 of individuals in fee-for-service delivery systems who present with uncomplicated back pain and no other conditions or symptoms receive an MRI on that first visit. Not watchful waiting, not some back exercises, because that's revenue. And people are not trying to be evil. It's just that they've been marinated in episodic fee-for-service care. Where you're starting to take on financial risk, you have an incentive to recognize, wow, maybe that's not the best approach, and to make much more judicious decisions. So ACOs are really primary care based, although they can be hospital led, even though primary care platform. Bundled payments are more directed towards specialty care and are conceptually analogous to DRGs, except it's across the entire care continuum. So for example, a bundled payment for joint replacement would think about everything pre-hand, the surgery, the cost of whatever's used, readmissions, trips to a rehab hospital, skilled nursing facility, all is in a single payment bundle. And so again, there starts to be thoughts about judicious use of care, care coordination, a higher level of discharge planning. And bundled payments have been both mandatory and voluntary. I personally expect that we will see more mandatory, because 17 conditions are responsible for 51% of the Medicare spend. And so it seems to me, we've got to really get on this. And this creates a lot of opportunities for care coordination and care at the least expensive setting. And finally, global budgets. I like to call them fixed revenue total cost of care models because they're less scary. Maryland has had a global budget for hospitals. Pennsylvania rural hospitals are using this model. Some of this is happening in Vermont. And this creates an environment where optimally the service area can align with the needs of the community. Let me give you an example. Excuse me. Excuse me. An example that I think is a fairly painful one. This was a small hospital in which the CEO told me confidentially he'd love to be in a global budget so they could really address the needs of the community. It was a community absolutely riddled with opioid addiction and a lot of challenging social determinants. And he said, I can't afford to let go of the golden goose, that's joint replacement and other orthopedics. There's an orthopedic center of excellence 30 miles away, but I'm continuing to do these, and sometimes not in a lot of volume in some areas, which brings up safety issues because I need the money from these elective procedures to keep the hospital afloat. So he could envision a world in which they could much better align to meet the needs of the community, but getting from that spot to the next seemed like a big hurdle. So when nurses understand financial risk, it is a real opportunity for the kind of value nurses can offer. Very briefly, a lot of our indicators are linked to payment. The hospital value-based purchasing program has many nurse-sensitive indicators. Some are totally nurse-dependent, and we're familiar with that, but often without the understanding of the upstream reason. So wouldn't it be wonderful in an interview, a student, bachelor's student graduating could say, I see that you're part of a risk-bearing ACO. I have some ideas on care coordination redesigns that could help you achieve the metrics while reducing cost. Or I see that you're part of a bundled payment arrangement for oncology. I have an interest in this particularly care across the episode continuum to prevent costly readmissions. And here's probably my favorite. Value-based purchasing arrangements are intriguing to me. I'm very committed to all 4 domains. Here's how I think I can contribute. Students could do this. We just have to help them learn this language, and it'd be an enormous contribution to society. Now, I don't want to run out of time, but I just want to mention that we need to embrace innovation in a value-based world. Remember that at one time, using a blood pressure cuff was considered to be outside the scope of practice of a registered nurse. It was physicians only. And now, of course, all kinds of people take them, do them themselves in their home. And we must expand to meet the conditions of our social contract with society, which is our moral authority to practice. And that includes embracing things like big data with predictive analytics and prescriptive analytics, artificial intelligence, deep learning, machine learning, data mining, natural language processing. Predictive analytics can predict with far greater accuracy who's likely to get admitted through the emergency department, who's going to develop diabetes, who's going to fall, et cetera, than we can clinically, and do so far before there's the beginning clinical manifestation. And we don't have to be the person doing the Bayesian statistics, but we do need to be able to look at those data and develop individual and population-based interventions. So in summary, nurses can be, and I believe must be, and I believe shall be, with all of your help and efforts, the vanguard. The social policy statement calls for nurses to be the vanguards in emerging areas. And remember Americans' concerns with costs. We can be the vanguard by understanding the interconnected nature of finance, economics, cost, outcomes, and policy. Knowledge is the first step. Propelling us to action, determine a course of action, and effectively identify the levers of change and how to influence them. Very important to understand what needs to be dealt with at the organizational level, the state level, the national level, or international. And that can be very murky to begin to understand where is the lever, and then take progressively more complex steps to leverage change in our society. So nurses as the value vanguard. So I went over just a little bit, but not too much, because I want to be sure we have time for questions. So Joe, can you, I saw some things in the chat, but it's a little hard to watch them all.
Yeah, so I would say people are being a little bit shy with the questions, so I would encourage people to ask questions, and we do have one that I'll get to, but I just wanted to start because we've got 80% of our audience is faculty. So I just wondered if you could talk about your experience teaching students at various levels and what they struggle with and what you think they need to know.
That's a great question. That's a great question. I have taught versions of this material at the master's level to practicing physicians, to medical students, to bachelor's or people working on their bachelor's degrees, RN to BS. RN to BS, it's probably one of my favorite areas because they're immersed in it and never understood it. But I've also taught it as a grand challenge course to first and second year students. And in that particular course, it's across disciplines. And students are very interested once they get past their initial sort of discomfort or thinking that it's not part of nursing. And, sometimes this kind of material is in contemporary issues classes, but I think it's actually really important to name finance, economics, ethics, ethonomics, policy, getting on boards. Because without that language, I think it's harder to sort of make traction. I think the hardest part is practicing nurses having sensed how deeply flawed our system is, but not really understanding what lies beneath. And I think that's very hard. And it's actually others as well. We love the virtue narrative, but we can't change things if we don't actually see them and name them. I had a physician a couple of years back who sent me a message that after the class, she decided she couldn't continue to do what she was doing. And she was going to go back for an MPH and really change her whole career because she really felt like she was part of a machine that she didn't feel good about being part of. So I think the main thing that's really hard is helping people understand that they not only have the right, but the authority to speak about this. Let me give you just one example. Just this month in the news, there is evidence of a monopsony, which is when one buyer can control the market. Some nurses have have filed an FTC complaint that there was non-poaching agreements in their healthcare systems, and that artificially kept salaries flat. And you can't have that. You can't have price fixing, right? So I couldn't help but wonder if more people had been exposed to these kinds of things, would have they understood that sooner? We have lots of mergers and acquisitions going on, and there's a lot of data that suggests mergers and acquisitions are not associated with lower cost or higher quality. And so how does a nurse, and many nurse layoffs sometimes, so how do they think about that? How do they think about interacting on these issues? I've also been surprised because I do a little survey and I included it in the book if anybody wants to use it. I'm still stunned at the number of people that don't vote and don't register to vote. And that's pretty alarming. It's only been a little over 100 years that women and people of color have had the right to vote. And, people in other places have died for that. And so that alarms me. So I think those things are a concern. I think that a surprise, I have them always do a little Jimmy Kimmel thing, asking people what's Obamacare, what's the Affordable Care Act. And the magnitude that they find that their parents don't know, this is undergraduate students, is sort of jarring. So I think it's hard, not because it's more difficult than other things they've learned, but just it's because it's so different than how they've been thinking about the role of the nurse.
Okay, thank you so much. And we do have some questions coming in.
Thank you so much.
So the first one is from Julie Baldwin. Are you seeing any movement with policy on palliative care? I do know we have hospice that is established, but I wanted to focus on that advocacy that give patients the opportunity to make decisions before they are faced with 6 months or less in hospice. I see nurses really being able to lead in this area.
Absolutely. And one of the things about these kind of bundle payment models is that they would absolutely lend themselves to this. One of the things that was a recent learning for me, I'm always sort of stunned at all that I didn't know about bad actors, but there actually has been a fair amount of fraudulent behavior in that realm. And so I think that that's been some of the reticence to expand. But it's deeper than that. It's a culture that really rewards aggressive treatment. If I just can tell a quick little story. When my father was actively dying, they actually suggested that he started on dialysis. So because his kidneys were failing. And I said, well, I think his kidneys are failing because he's dying. What do you think? And I asked, do you think it would help him die more comfortably? And they said no. So if I hadn't asked that question, if I would have been propelled into we got to do everything we can, you would have started on dialysis. You know where that would go. Then we would have had to make that horrible decision about removing it. And so we have to do better. And I do think that as part of the value vanguard, getting this language out there and understanding that overtreatment at the end of life is so painful for everyone, except remember, it creates a lot of revenue for some. And it's not that groups are malicious. It's just that we can't trust altruism. We have to create the economic systems. So I absolutely agree that nurses can and should lead the palliative care effort. And we actually have a new endowed chair in our institution. And I'm really wanting to think with her about how do we connect that very tightly to this issue of cost, waste, revenue, overtreatment, the national debt. Because people want to die for the most part, in the least invasive settings. And how often do we see this? Died in the hospital after a long illness, right? So you're absolutely right. And I'm sure you have many more ideas on this than I do. But I do think coupling it to value shared decision-making, right? If people really understood that they did X, Y, and Z, and their chance of doing well is, it might make a difference. Another big area is cognitive disorders. In some countries, New Zealand, for example, nurses do a routine screening in the primary care setting on cognition so that from the very beginning, they can develop a home and lifestyle modification program to support those individuals in the least intensive setting. And it includes having family members have 28 days of respite a year, including people coming in the home. And then the specialist care, the neurologists are saved for certain kind of people that are not the typical. And some work I've done with a colleague who's a geriatric nurse practitioner, in the work we found, often when people in the United States realize that the person probably has a cognitive disorder, they send them to the specialist. And they're saying, well, that's what it is. Why would you send them to the specialist? So we have so many areas that we as nurses really are the bridge to a better future. But we're stuck in a payment model that still disproportionately reimburses hospital and physician-centric care. So you're absolutely right. I often say we have to create the world we want to die in, right? So we've got a lot of work to do.
Okay, here's a short question from Ann Devaney. What can we do as associations, groups, and individuals?
That is a great question. And I often think it's so important for us to do what's right in front of us. I mean, I sometimes have this sense that there's this world of burning fires everywhere. And oh my God, global climate change. So what can I do? So I think it depends on, your situation. If you're a faculty member, you certainly can bring these things into the class to make them live, give tools to the students. You can demystify the political process, encourage people to run for office, get behind candidates that you support. I personally think that it is absolutely essential that we get off the fee-for-service bandwagon. And that is hard because there's a lot of players who do very well financially in this realm. So I don't have a specific answer for you because I don't know your situation. But I think, for example, for myself, I've done different things at different times. I led a health reform effort in the state of North Dakota in the Bill Clinton era. I later on found out the only reason I got the role of chair is nobody else wanted it. It was too much of a political hot potato. How did I know? As dean, I tried to shape curricula to bring these things in. I sat on the Green Mountain Care Board to try to create a new model of care. I'm on MedPAC now, which advises Congress on Medicare policy. And I have to a disclaimer, these views are my own. So I think it depends, but I do think that if you stop and think, what can I do? What's my piece of the vanguard? It will come to you. One of the students I've been working with this semester, undergraduate student, just said, this is the area of nursing I'm interested in, but I didn't think it was nursing. Yeah, it's nursing. And so he'll decide, but there's also the opportunity in more specific areas like children's health, adolescent mental health, whatever. So, and I also think associations could really help us by pushing value-informed nursing practice. I have personally been pushing that the AACN Essentials, the one that's safety and quality, safety, quality, and cost, or safety, quality, and value, because it really doesn't matter if it could be delivered safely if you didn't need it in the first place, or nobody can afford it. So I think we really have to start talking affordability. And just to underscore, 70% in recent studies, 70% of Americans want their healthcare providers to discuss cost because, they're bearing more of it now with cost sharing. And yet, it's just reported in Wall Street Journal yesterday that hospitals are not fully complying with the requirement for transparent pricing that came into place in January, that it's there, but it's so difficult that no one can find it. So I think to the extent that we demand information, both as consumers and providers, about cost, value, outcomes, redundant care, we'll be doing our work. One of the things I'm doing is being here with you. So you're doing something by being here. So thank you.
Okay, so we have about 4 minutes left and we have 2 questions.
I'll be brief, sorry, thank you.
Oh, it's okay. So Gwen Christensen asked, at the RN to BSN level, how do you suggest getting the students to first understand all of the language and then taking steps to demonstrate how they can make an impact on change? Can you provide an example?
Yeah, that's a great question. So I have actually, the first edition of the book that I wrote was actually the materials that I had compiled for the RN to BS class, because I love teaching that level of students. And, they're so marinated in care. And this opportunity to look up and over and over again. So I elbowed my way to insisting that we have a class on this in the RN to BS. Over and over again, they said it was the most eye-opening class, and they found it really interesting because as you start talking, they've seen it all. They've seen it all. They just didn't know about terms like supplier-induced demand and moral hazard. And so they become very interested in it, both as providers, but also as citizens. So I have found that that's the group that has the most ahas almost.
Okay, and the last question is from Cindy Cook. How can bundled payments be tailored to each patient and still benefit the provider health system? I'm sorry, there's a little bit more. Such as an older patient undergoing a total joint replacement that is not allowed to go to rehab because of bundled payments.
Yeah, I think that's the other side of bundled payments is if there's only this much money, are we going to be denying care? And the thought around this is that they really have to be risk stratified, that the payment has to be by risk stratification. And there's more and more discussion about that because without risk stratification, expecting to pay more for a sicker patient, you have a challenge. So that's been one of the problems with bundles. But in a number of the bundle payment experiments, they have found lower costs and better outcomes without some of those adverse effects.
Okay, great. Thanks to everybody for the questions and your answers, Dr. Rambur. We can go to the book. Next slide.
Thank you so much for being here.
So Dr. Rambur's latest publication, the second edition of Healthcare Finance, Economics, and Policy for Nurses, a foundational guide, will publish in late April. It serves as a core resource for courses on healthcare finance and policy and is adopted in MSN, DNP, and RN to BSN programs. For more information, please visit springerpub.com. All registrants who joined us today can use the code webinar25 to receive a 25% discount. And those interested in considering the text for adoption can request a copy via springerpub.com/educators. It looks like we've covered all of the questions, but if you have any additional questions, you can reach out to us at marketing@springerpub.com. Thanks everyone for watching. It was a pleasure being with you today. You will receive notice when the video of the session is available in about a week. Until next time, stay well and goodbye. Thank you.
Thanks for being here.